I call upon Dr. Sam Alsohaily. Dr. Sam is a consultant gastroenterologist at Campbelltown Hospital and researcher at Garen Institute, and he's a lecturer at University New South Wales and University Western Sydney. Dr. Sam will talk to us about facts about fatty liver disease in diabetic.
Thank you. I'll try and make it brief just to catch up with time. Hopefully I don't go the 15 or 20 minutes as well. So it's just a brief message about fatty liver disease and diabetes, which is a problem that a lot of people in the audience probably face. It's not only gastroenterologists and hepatologists, but endocrinologists, GPs, dietitian, physiotherapists, people who deal with metabolic syndrome will come across fatty liver as well. So stages of fatty liver disease. From a healthy liver, we get into hepatic steatosis, which is just a simple fat in the liver, into steatohepatitis, which is fatty liver plus inflammation, and then into fibrosis. And, oh, that doesn't come up, sorry. There we go. So it goes into stages from hepatic steatosis into steatohepatitis. Both are reversible, and then finally we get into fibrosis, and advanced fibrosis means liver cirrhosis, which gets into the irreversible stage. So what about NAFLD, or non-alcoholic fatty liver disease, and diabetes? Up to 70% of people with diabetes will have fatty liver disease, and that's much higher than the general population. Biopsy-proven non-alcoholic steatohepatitis, or NASH, is present in about 20%, and advanced fibrosis in 5 to 7% of diabetics. The risk of developing diabetes also increases in patients with non-alcoholic fatty liver disease by about 5-fold. And we now know that type 2 diabetes actually worsens the histology of fatty liver. So we get more advanced phase of fatty liver disease, whether it's non-alcoholic steatohepatitis or advanced fibrosis and cirrhosis in people with diabetics. They're more susceptible to develop NASH and also at higher risk or higher rate of developing hepatocellular carcinoma. So how do you define fatty liver? It's basically simply the presence of hepatic steatosis when there is no significant alcohol consumption and no other cause of elevated liver enzymes or fatty liver, for example, Wilson disease, alcohol, and other causes. We rely on simple algorithm. We check liver function tests regularly for our diabetic patients. I think it's just part of the regular routine checks. But be wary that fatty liver can be present in the with normal ALT and normal liver enzymes. It doesn't rule it out, and even sometimes steatohepatitis or fibrosis. Imaging with ultrasound, we always sometimes see reports of increased hepatic echogenicity on ultrasound, which usually refers to fatty liver. On CT, it appears hypo attenuating. MR elastography is now being used as well. Liver biopsy remains the gold standard, but we rarely refer to liver biopsy for a simple fatty liver. It's just basically diagnosis based on imaging and exclusion of other causes. In a patient with diabetes and fatty liver, try to assess the presence of fibrosis, because that's really the important. If there is simple steatosis, your patient will not die from complication of liver disease. They will die from cardiovascular disease. But if there is advanced fibrosis, that's when your patient could progress into cirrhosis. Especially diabetics are at higher risk of getting into cirrhosis and hepatocellular carcinoma. So sometimes your patient might have normal LFT, and then you could see them having liver mass lesion and HCC secondary to fatty liver and steatohepatitis. So be wary assess the degree of fibrosis. So there are a few scores. We use, the most widely used, we use NAFLD fibrosis score calculator, and these calculators are present online. You can easily just put NAFLD fibrosis score calculator. Most of the calculators rely on age, the presence of diabetes, ALT, platelet, and albumin. That's the general way to look at patients and assess whether they have advanced fibrosis or not. There's the FIB-4 score, which a lot of hepatologists like as well and use. And then we have non-invasive imaging means like the fibroscan, the elastography, the transient elastography. The problem is in patients with high BMI, obese, it might not be accurate. So you have a fibroscan reading of 4, which means it's normal or minimal fibrosis when they actually have nodular liver when you do ultrasound or CT. So don't always rely on them, but they are a good additional ways of assessing the degree of fibrosis and advanced fibrosis. So that's the NAFLD fibrosis score, and you can have an online calculator. And as I said, mainly age, BMI, diabetes, and platelet, ALT, AST. So I don't necessarily agree with all what's on the slides. That's from actually an endocrine journal talking about patients with a pre-diabetes or diabetes. ALT and ultrasound normal, I think that's fine. You can just periodically reassess. If they are abnormal, then you need to assess for the presence of fibrosis. But also in people who have long-standing diabetes, high BMI or morbid obesity, and patients who always have high HbA1c. Even with a normal ultrasound and ALT, beware of the presence of fibrosis. Liver biopsy is rarely used. We use other means and then maybe refer if in doubt. The aim of treatment is to reduce disease activity and delay progression of fibrosis. But as I said, majority of people with fatty liver disease actually die from cardiovascular risk. So make sure you try and modify their cardiovascular risk, and high triglyceride is a good indicator. We say lifestyle intervention and modification. I'm sure a lot of people who deal with diabetic patients, you try and relay this message to your patients. It's sometimes hard to achieve good weight loss, hard to maintain, and adhering to a lifestyle intervention for a long time is something difficult. But we now know for a fact that if you lose 7% of your diabetic patient, obese patient, lose more than 7% of the total body weight, that improves the steatosis and necroinflammation, the steatohepatitis. If they lose 10%, they get regression of fibrosis. And that's, so the weight loss is the key message, and therefore obese patients with diabetic, well, they might benefit from bariatric surgery. We now know that for a fact that it reduced steatosis, the degree of steatosis, biopsy proven by in about 90% of people, and actually regress fibrosis in about 50% of people. That's from sleeve studies. There are weight loss medications. The orlistat, liraglutide can also be considered. Pioglitazone, I know it's not on so much in practice these days, and there are some potential side effects, but it's the proven medication that improve steatosis, inflammation, and fibrosis. There are potential adverse effects, including some studies suggest increasing risk of congestive cardiac failure, bladder cancer in men, and the most important problem is weight gain. So that's something that you try to avoid in people with NAFLD. It helps steatosis, but it makes people put on weight, and for obese patients it's a problem. Vitamin E has been proven to reduce progression of fibrosis and steatosis, but it's in high dose. So the most studied dose is 800 unit, which is not available. So I tell my patients to take 1 tablet of 500 one day, 2 tablets the next day to try and even it. But there are, again, some potential side effects. Vitamin E is a good antioxidant, helps with fatty liver disease, proven in people with fatty liver disease. However, there were some studies suggest that there is an increase in all-cause mortality. That has been a bit of controversial area because some studies showed increase all-cause mortality, others didn't. And meta-analysis said it's neutral. So we don't use it on all people. We try to be careful about using vitamin E. It also potentially can increase the risk of prostate cancer in men. So men, family history of prostate cancer, I don't use it. Women, maybe. Mainly if they have steatohepatitis, we think they are at risk of progression of fibrosis, well, we're going to use something and it's safe to use. Liraglutide has a proven efficacy as well. I think I'll skip this busy slide just in the interest of time. But again, the most important message for you is control cardiovascular risk. Not only think about fatty liver in people with fatty liver. So think about fatty liver when you see a diabetic patient. You need to know that diabetics are at more risk of severe form of NAFLD, and that's including steatohepatitis, liver cirrhosis, and progression into hepatocellular carcinoma. They are at higher risk of HCC. We see actually a lot of patients with HCC, unfortunately, in diabetics. And first diagnosis, liver cirrhosis, liver mass, proven hepatocellular carcinoma. So be aware of that. Non-invasive methods are available. And you can use the NAFLD fibrosis score. You can use FibroScan and transient elastography. Liver biopsy rarely needed. Remember, if you advise your patient to lose 10% of total body weight, that results in regression of fibrosis. Lifestyle modification remain the mainstay, but it is challenging to maintain. And you have some options of pioglitazone, which, it's on the fence. Vitamin E in appropriate patients is good choice, especially people with NASH or people you worry about progression of fibrosis. And, bariatric surgery, remember, results in regression of fibrosis. So even people who have proven cirrhosis, sometimes they do regress, which is thought to be irreversible, but people who lose good amount of weight through bariatric surgery often could regress. I think I'll stop here and
Thank you very much.
I'll try and keep it short and simple.
Sam, I might ask the first question.
Yeah.
Patients with type 2 diabetes who are overweight have abnormal liver function tests, very common.
Absolutely.
Which of those patients, and I'm sure the GPs have the same thoughts in their mind, which of those patients need further imaging and also need assessment for fibrosis? So how do we decide, because it's so common?
Yeah, look, a lot of diabetics do often have high GGT, and that's indicative of a degree of fatty liver. We often look at ALT more than GGT. And if the ALT is elevated, ferritin is elevated, that might indicate a degree of steatohepatitis. And sometimes we see low albumin, low platelet, that's probably more advanced degree of steatohepatitis. But the one with high ALT, especially if it gets in the hundreds, I will worry about them, and they might have an advanced degree of steatohepatitis. Yeah. All right. Thank you. Thanks.